A study by the International Journal of Drug Policy has revealed an increase in the number of people taking illicit drugs in South Africa. Most of them have been consuming marijuana, cocaine and heroin since the early 2000s. It's also been found that many drug users are not testing for HIV. Let's unpack more broadly some of the findings from this study. Professor Nadine Harker is a specialist in alcohol, tobacco and substance abuse at the South African Medical Research Council. Prof. Harker, it's great to talk to you. Thanks very much indeed for coming on to the program. It's alarming, isn't it, the numbers that have come out of this study. In 2002, fewer than 2% of the people surveyed in South Africa said they had taken illicit drugs. Fast forward 15 years, and that number had climbed to 10%. I wonder what they look like now in 2024.
Yeah, that's a good question, and good afternoon to you, Michelle, and your viewers. We have seen an increase in certain substances. Of course, this was post-1994 when borders became more porous and South Africa was seen as an unsaturated market. I guess prior to 1994, we battled cannabis mostly, methaqualone and alcohol. But more recently, we've seen heroin, methamphetamine, cocaine climbing, and then, of course, the non-medically indicated use of over-the-counter medications and prescription medications. And I suppose we can't leave alcohol behind, especially heavy episodic drinking, although that wasn't the scope of the study.
And I wonder, Professor Harker, how, the fact that marijuana in 2002 legislatively was completely different in terms of its classification. I wonder whether people would have been as honest in 2002 about, for example, cannabis use?
Probably not. Substance use in general is stigmatized and associated with things like low morals and lack of willpower. So people are probably more inclined to disclose now. But I think the data that we do have is data that could probably be recorded a little bit better. When I say that, I speak really about more frequent household surveys as opposed to what we currently have. We draw a lot of our data from treatment demand centers and community harm reduction centers, and then the ad hoc type of surveys that are not dedicated to substance use per se, but we do need more every 3 year, every 5 year type of household national surveys that would give us better estimates, and also look at perhaps data on past 30 days drug use or past 7 days, age of initiation, patterns of use, modes of use.
Yeah, I'd be interested to know as well, what or how pharmacies can contribute to this kind of research. Because as you say, the stigma with taking any kind of drugs is perhaps of someone who has low self-control, low morals. Is that put into your research as well, or into this kind of research? What do pharmacies say about the use of, pain relief medicines that include codeine, for example?
Codeine falls under the opioid descriptions and so forth, and it's highly addictive. And there is legislation that currently exists around how to dispense codeine. But I think one of the important aspects around that is codeine use or using medicines non-medically is not always understood. And something really simplistic would even be the little pamphlets that's in the medicine boxes. How many people actually read those? How many pharmacists perhaps engage on these topics when someone presents repeatedly with a need for codeine medications? So I know some large pharmaceutical dispensers would have national registers so that they can possibly track and intervene. But the degree to which that happens, I'm not really sure of at this stage.
Yeah, and I know some medical aids, if not all medical aids, won't give you a certain medication within sort of a 30-day period. They won't give you a repeat of a certain kind of medication, right?
Yeah, highly scheduled substances or drugs.
So what do you put that down to, Professor Harker, this 161-fold increase in people that said that they used an opioid, and it's the class of drugs that we're talking about that includes pain relief medicines like codeine? What do we put that kind of increase down to?
I think substance use, including medicine misuse, is very complex, and there are lots of factors that interact and contribute to any individual's likelihood of engaging in drug use, including you and I. And here we speak, about socioeconomic factors, but also other factors. So I think if we look at the drivers or the predictors of substance use, we think of poverty, income, unemployment, those come to mind. And we do know that those with poor, no, or unstable employment, they at an increased risk for using substances, sometimes as a coping mechanism. But we also know how drugs interact in a sense that it makes you feel a little bit better in sense, takes away the sting of poverty. It makes you feel less hopeless. And there's with unemployment and poverty, there's pervasive hopelessness that exists. Also, schooling and education, I think, could also be a predictor. I mean, we know that lower levels of education could be a protective factor against substance use, but we also know that early dropout of school is potentially a predictor for higher rates of drug use. And if you have better opportunities and good job prospects, that's really linked to having a sense of purpose, and is a protective factor in the sense that it would reduce the likelihood of turning to substance use. And then I guess, Michelle, there are other things such as community characteristics. We think of communities where there are permissive social norms. We have communities, high crime neighborhoods, where there's lack of support, limited networks, limited access to recreational activities, especially for young people, in particular, who are most vulnerable. And then, of course, there are also cultural attitudes. I mean, some perceive it as acceptable, and some perceive it as total taboo, and all of these things influence initiation and continuation. The nature of the substance, of course, whether it's methamphetamine or heroin, that plays a role in that they all affect the body in a different way. Other things such as your family systems, parental or caregiver use of drugs, especially in a family where there are young people, that also creates permissiveness. I also would think that families that have experienced severe trauma over time, families that have been displaced, and then other issues such as poor parental supervision or engagement. That would be probably a driver, or is a driver. And then we must remember that there's limited access to healthcare and mental health services. If you link it to stigma, it's not easy for an individual to seek services, especially if they've been victimized in the past, if they have been mishandled in any way or form. That would create hesitancy. But also on the other side of the healthcare, and it relates to your question about codeine also, is self-medicating. So if you can have no access to codeine, you could resort to self-medicating with other substances. And we know that these are easy to come by. There's easy access to drugs, so availability and accessibility, geographic location, law enforcement, they all play a role really into them. That's why I say that it's complex rather than simple.
Yeah, it really is.
Simple answer. Yeah.
It really is, and I'm glad that the tone that you've taken as well, Professor Harker, is, not that we're speaking from any kind of higher ground here, that this is not a judgmental conversation in any way, just because of how much of an issue socioeconomic conditions is when we're talking about drug use, right? You've talked about geographic location also being an issue. And I see here, as part of the trends outlined in this research, the trends, according to the research, are ubiquitous across race and across class. So there really is no one race or class that we can say is more prone to drug abuse. But it's interesting to see the numbers coming out of communities on the Cape Flats.
Yes, indeed, and I mean, that's no secret, the problems. I mean, the Cape Flats are also, there's a lot of gang violence. It's also trade of substances to those that are vulnerable. So, but what I would also say is the Cape Flats is probably one of the problematic provinces, but we've also found through our treatment demand data through the South African Community Epidemiology Network on drug use that there can be variations, and these happen over the years or over provinces. You might see a spike of a certain drug in the Western Cape, but in 5 years we'd see the same drug that wasn't as prevalent in Gauteng suddenly emerge. For instance, methamphetamine as well is a substance. It's a synthetic illicit street drug, but it's quite common or commonly used in Gauteng in certain areas, but not so common in the Eastern Cape, for example.
Yeah, that's very interesting indeed. And it can bring us to another discussion around the increase in drug trafficking in our country as well. But I want to ask you this, Professor Harker. One of the things that are being proposed is to roll out opioid substitution therapy as a replacement for heroin. How would that work, and why would we replace one drug with another?
Okay. I can see why that would cause alarm. And I think there's probably a little bit of a misconception there around what OST or opioid substitution therapy is. It's also known as opioid maintenance therapy or opioid agonist treatment. And it is a medical approach to use or that we use to treat individuals with opioid dependence. So it is a therapy that is advocated for by the World Health Organization, and it's considered evidence-based. And we all know, we should know that opioid addiction is quite difficult and complex to treat.
Right.
And this is the manner in which WHO proposes to treat it. And the primary goal of OST is to reduce the harms associated with opioid use, so that the individual that is involved harmfully can achieve some level of stability, because it's incredibly hard to come off heroin by yourself.
You can't go cold turkey.
You can't go cold turkey. So there is some level of therapy involved, medical therapy to assist the individual with the express purpose of reducing cravings, because it is difficult to, like you said, to come off cold turkey. And the idea of OST is to make it easier for the individual to abstain from illicit substance use or illicit drug use or illicit heroin use. Yeah. But also, Michelle, the physical and the psychological withdrawals that stem from opioid use is severe. And the idea is not to contribute to a cycle of relapse all the time, because that in itself also contributes to loss of hope and it being stuck in a vulnerable situation. Yeah. The other thing that I need to underscore about opioid substitution therapy, it's also a measure to reduce harm, because when it comes to opioids, there's also a high risk of migrating perhaps from smoking heroin to injecting. And there we start delving into the transmission of infectious diseases. So we start talking HIV, hepatitis, TB, and that can be quite prevalent in this population or this group of people who inject drugs or even use drugs because of the compromised immune system that they would have. So the idea is to also reduce the harms via opioid substitution therapy, which reduces the risk to inject or to use. And the ultimate goal really is to link the individual. So it's not by and in itself a solve all. It has to go hand in hand with psychosocial therapy, vocational training, so that the individual becomes and is able to live a relatively normal life.
Yeah.
Professor that sort of explains it
absolutely.
And unveils it a bit for you.
Yeah, it's a holistic program. It's not just a sort of one-size-fits-all insofar as trying to deal with an issue like heroin or opioid addiction. Professor Nadine Harker, it's been a great pleasure talking to you this afternoon. Thank you for coming on and giving us some clarity on these issues. And hopefully conversations like this do remove the stigma so that people can get the help they need when they need it. Professor Harker is a specialist in alcohol, tobacco, and substance abuse.